The trenches today, I was asked to talk about a very challenging medicine, warfarin, and warfarin use. Since 2014, when DOACs became approved for VTE, and before that, when they got approved for AFib, we haven't been using as much warfarin. And that made my life as a clinician and a physician interested in blood clots a lot easier. Warfarin was rat poison. Basically, the acronym Warfarin stands for Wisconsin Alumni Research Foundation for Rat Eradication. They gave this to rats, they bled to death, and somebody came up with the idea of using this to treat blood clots. So to go over how this works, we really have to go over the coagulation cascade. So I'm going to draw this here, 12 to 12A, 11 to 11A, okay, 9 to 9A, 10 to 10A, prothrombin to thrombin, fibrinogen to fibrin, fibrin to fibrin's blood products. That's factor 13 here. That's stable fibrin, my mistake. So fibrin to stable fibrin is factor 13. Excuse my awful handwriting. Okay, this is, starting here is the extrinsic pathway. Here, factor 5 is a cofactor here. And here we have this is the intrinsic pathway, and the extrinsic pathway, we have tissue factor, which inverts factor 7 to factor 7A, and converts factor 10 to factor 10A. Okay, these are the procoagulants. Anticoagulants, you have protein C and protein S. Okay, and these kind of antagonize factor 5 and factor 8 level. Okay, this is a lot of scribble on the board here, thanks to me. And we're talking about warfarin. So where warfarin inhibits the vitamin K dependent factors. So it inhibits factor 2, factor 7, factor 9, factor 10, and protein C and protein S. So factor 2 is prothrombin, factor 7 is proconvertin, factor 9 is Christmas factor, factor 10 is Stewart factor. This is where this works. And it takes time for it to work. But what happens is this. Now, along all these, you have factor 4, which is calcium, and you have phospholipids. And they're involved in the coagulation cascade, and they allow these factors to interact with each other in order to form a blood clot. Vitamin K is involved, okay? And what happens is, in these factors, coumadin, warfarin inhibits, coumadin's the trade name in the United States, inhibits the enzyme vitamin K epoxide reductase. And that prevents carboxylation of the gamma carbon. on 2, 7, 9, and 10, and it prevents them from interacting with calcium and phospholipids. So things don't work. That's how it works. And there are really two forms of warfarin. It's a racemic mixture. There's the R, the less potent, and the S, the more potent. Okay. Again, what does all this mean? You're dosing cumin. How much do you give a patient? And when you're treating people, especially with VTE, if you have to use it, you need an overlap period. Okay, so you need at least 5 days, usually more, 5 to 7 days, where you're on both heparin and warfarin, or low molecular weight heparin and warfarin. Factor 7 has the shortest half-life of the factors. Okay, but even if you inhibit that, you have to inhibit the other factors, and it's really about inhibiting prothrombin, which goes to thrombin. So, depending on the patient as a whole, a larger person will need more warfarin, and a more petite person won't. Ethnically, African American people of color might need a little more. Asian people might need a little less, but this is, it's not a hard and fast rule. Diet high in vitamin K, okay, you're going to need more warfarin to inhibit that. Diet low in vitamin K, foods like like spinach or leafy vegetables, you're going to need less. They have to be on a constant diet. And then there are medications that interact with it. Okay, so like the most common antibiotic is Bactrim. If you have somebody on Bactrim, Bactrim inhibits the R form, and you get more of the S form, which is the more potent warfarin. And you measure warfarin with an INR, you want an INR to be 2.3. You're more prone to bleeding. Other antibiotics like erythromycin, the quinolones, they could also do this. So there are lists of medications that interact. One of the toughest ones is amiodarone, because that could really prolong your INR. And amiodarone is often used with cumin, or was, now not as much, patients with AFib, but it has a very long half-life of 55 days. And with warfarin, you're often changing the dose. Okay, the other thing, it's not really controversial. Protein C inhibits factor 5 and factor 8 a little bit. So if you're deficient in it, or if you have resistance, you're slightly hypercoagulable. And protein S serves as a cofactor with protein C. And they have very short half-lives. So theoretically, when you give warfarin, if you don't have another anticoagulant on board, you're transiently hypercoagulable. And there's a condition called warfarin skin necrosis, where you get skin necrosis in fatty areas like under the breast and the buttocks due to this phenomenon. You need to be aware of it. Now, where are you going to use warfarin? You're going to use it with mechanical heart valves. That's clear cut. You could use it if somebody has a large MI and a left ventricular thrombus, you might use it. And then if somebody has the antiphospholipid antibody syndrome, we had a patient in the office yesterday with that, and that stimulated my medical student, Carmine, to ask about warfarin. And he's going to have to be on it, and somebody's going to have to manage it. They're going to have to go over his diet. They're going to have to go over concurrent medications, and he's going to be monitored. This stuff could change. And, if you're not in the therapeutic range, you're not going to be anticoagulated. And if your INR is too high, you're at risk for bleeding, including intracranial bleeding. So basically, warfarin is now become, thank God, more of a B team player, a bench player in the world of anticoagulation, but still has a role. And some people's insurance companies will not pay for DOACs, and they're not generic yet, and they have to be on this medicine. And, loading it, the idea is not to super load it because you can bump up the INR and then you come down. And really, it really depends on the size of the patient, and then you have to check an INR and then you have to monitor for the first month. You're checking INRs close to weekly to make sure you get the right dose, which is usually an INR between 2 and 3. And it works by inhibiting the vitamin K defendant factors, okay, by inhibiting the enzyme vitamin K epoxide reductase. And remember, it's a racemic mixture, and that's, some medications affect the balance between the more potent S form and the less potent R form. And what else could I say? Once in a while, it could cause hair loss, and it could be associated with vascular calcification in renal patients. But we'll leave that for another time. With this, I'm going to stop.